be dealing mainly with about hemophilia. Before going into hemophilia, I'll be classifying the hemorrhagic disorders. Hemorrhagic disorders are broadly classified into platelet or vascular disorders, and the second is coagulation disorders. So what is the difference between this platelet or vascular disorder and the coagulation disorder? The platelet or vascular disorders, it is always produced by superficial bleeding with formation of petechia and ecchymosis. That is, in platelet disorders, you will get purpura, whereas coagulation disorders, it is produced by deep in the tissue, and it can produce severe and bleeding and extensive hematomas. So, platelet or vascular disorders is characterized by purpura, that is by superficial bleeding with formation of petechia and ecchymosis, whereas in coagulation disorders, it is characterized by severe bleeding, deep in tissue and extensive hematomas. When all these extensive or bleeding occurs, it can be either from a superficial injury, or after surgeries there can be a prolonged bleeding, or in cases of trauma there can be bleeding. And if the bleeding is excessive and the collection is huge in the deep tissues, it can be lethal. So what are the common platelet disorders? The common platelet disorders are thrombocytopenia, idiopathic thrombocytic purpura, AIDS-associated thrombocytopenia, leukemia, von Willebrand's disease, and certain drugs also can produce thrombocytopenia. That's mainly cytotoxic drugs, and such thrombocytopenia are called as Glanzmann syndrome. The main coagulation defects are hemophilia, von Willebrand's disease, anticoagulants, and jaundice also can produce coagulation defects. The rare causes of hemorrhagic disorders are aplastic anemia, chronic renal failure, and multiple myeloma. So coming on to hemophilia, hemophilia, it is mainly affected in males. It is an inherited bleeding disorder. It affects 1 in 7,500 males. And coming, there are 4 types of hemophilia: hemophilia A, hemophilia B, factor 11 deficiency, and von Willebrand's disease. In hemophilia A, there is deficiency of factor 8. It is usually an X-linked recessive trait. In this, mainly the males are affected. Females are mainly carriers because only one sex chromosome is usually affected. But if both the parents are hemophilic, then there is a 50% chance that the female can get hemophilia if both the sex chromosomes are affected. Both the X chromosomes are affected. Moving on to hemophilia B, it is due to the deficiency of factor 9, otherwise called as plasma thromboplastin component, or it is also called as Christmas disease. Factor 11 deficiency, it is an autosomal recessive trait, which is 3rd category, and the final one is von Willebrand's disease. This is due to the deficiency of von Willebrand factor found in platelets, megakaryocytes, and endothelial cells. And this von Willebrand's factor, it is always associated with factor 8. So von Willebrand's factor circulates in conjunction with factor 8. In hemophilia, the primary platelet plug formation will be normal, but due to the deficiency of thrombin, the secondary platelet plug formation is defective, and the primary platelet plug can get dislodged due to the deficiency of thrombin. It becomes friable after some time gap from the primary wound. There will be excessive bleeding. So platelet adhesion to subendothelium via collagen, and there is formation of primary platelet plug. And what are the what are the bleeding sites you see in hemophilia. Bleeding from skin can be seen, mucosa, then bruising of the surfaces can be seen. Then epistaxis, that is bleeding from nose. Then bleeding can occur after surgery. Uh, and one of the main bleeding sites is the bleeding involves the muscles and joints. That is, bleeding, the blood can accumulate in the muscles and joints, and it can lead to crippling conditions. Then hemophilia can be classified into mild, moderate, and severe. Severe is less than 1%. That is, in this category, you can get spontaneous bleeding without any reason. Bleeding can start, and if the bleeding starts, then the blood can accumulate in the joints and muscles. 1 to 5% cases are moderate. Here, occasional bleeding, spontaneous bleeding occur. That is, whereas in severe there is frequent spontaneous bleeding, whereas in moderate only very rare chance of spontaneous bleeding occurs, but bleeding can occur in minor trauma also, which can initiate this bleeding episode. In mild, there will not be any spontaneous bleeding. The bleeding is always associated with a cause like trauma. When trauma occurs, bleeding occurs, and that can lead to accumulation in bones and joints. And the moving on to the clinical features, what are the common clinical features we can see is mainly hemarthrosis. That is, we have already told that there can be bleeding into the joints and muscles. So when blood gets accumulated in the joint, it can produce damage and crippling condition. And if bleeding occurs in the abdominal cavity, then the patient can experience severe or acute abdominal pain. Then bleeding can occur in cranium and bladder, since these are the organs which have many functions, and these are the organs or tissues which control our body. When bleeding occurs in this in cranium and bladder, it can be fatal. So what is the duration of bleeding in a hemophilic patient? As the primary platelet plaque formation is normal, so soon after trauma there will be a cessation of bleeding, but after some time again the bleeding restarts. So bleeding in hemophilia stops immediately after injury, but after an hour or more there is rapid blood loss, which starts spontaneously and can persist over a time. The severity of the bleeding depends on two factors, that is level of the factor VIII concentration in the blood and the severity of the trauma. And what are the diagnostic tests that you can do in a hemophilic patient is activated plasma thromboplastin time can be tested, which will be prolonged, and there is decreased factor VIII. But the patient has normal bleeding time and platelet time. The management, moving on to management, the mainstay of therapy, since it's deficiency of factor, the mainstay is to supplement the factor which is deficient. So mainstay of therapy is purified concentrate of the missing factor. It can be extracted from the blood plasma. But again, there are many shortcomings for this, because the short life of factor VIII is very low. It is around 12 hours. So once it is transferred from a donor, the factor VIII should be only active for only almost 12 hours. Then it will be useless. And other supportive agents are desmopressin acetate, which can be given as IV in mild hemophilic patients. And how does it work? It increases factor VIII activity to 300 to 400 percentage 2 hours after infusion of 0.3 to 0.4 milligram per kilogram body weight of the drug. That is, if desmopressin acetate is given to a hemophilic patient with factor VIII deficiency, there will be a booster in factor VIII activity 300 to 400 percentage after 2 hours of injection. And the dosage of desmopressin to be used is 0.3 to 0.4 milligram per kilogram body weight. It reduces release of factor VIII that is normally bound to vascular basement membrane. Next supportive drug is epsilon aminocaproic acid used as adjuvant in this factor therapy. So along with factor VIII, you can also give epsilon aminocaproic acid. What is the action is normal fibrinolytic mechanism is there. The primary clot formation is almost normal, but generation of thrombin necessary for clot formation or clot stabilization is either inadequate or retarded. So then whatever is formed becomes loose and friable and is easily dislodged. The fibrinolytic mechanism is effectively inhibited by epsilon aminocaproic acid, allowing more stable clot to form and retract. So this, whenever this is given, the clot formation becomes more stable. What are side effects is it can produce hypotension, nausea, and vomiting. Then another group of supportive agents is tranexamic acid. This is 10 times more effective than epsilon aminocaproic acid. What are the complications that you face in hemophilia? Is 5 to 20% of hemophilics develops inhibitory antibodies. So when this bleeding episodes occur often, so in 5 to 20% of these patients, they develop antibodies. And if that antibodies are developed, if these inhibitory antibodies are developed, bleeding episodes are more difficult to control. So patients with low titer effect may be overcome by high doses of concentration. So whenever the titer is low, we have to increase the concentration factor 8 or 9, whichever factor is, that concentration should be of high doses. High titer effects of inhibitors may be bypassed through the use of prothrombin complex concentrate of 1-deamino 8-dearginine vasopressin. So whenever high titer has to be used, it also has to be supplemented with 1-deamino 8-dearginine vasopressin, because effects of inhibitors may be bypassed by using this medication. And the complication of this is the risk of HIV and hepatitis B infection. So heat treatment of pooled donor factor eliminates infectivity of both HIV and hepatitis B. Now moving on to the dental treatment, what all we have to consider when you do a dental treatment in a hemophilic patient is you have to really have relief of anxiety, because there is a direct relationship between anxiety and antifibrinolytic activity. That is, when anxiety increases, the antifibrinolytic activity also increases and bleeding also increases. So you have to control the anxiety of the patient. You have to reassure the patient. And next is nitrous oxide oxygen inhalation analgesia can be used, and hypnosis also is beneficial. The one thing that is contraindicated in hemophilia patient is intramuscular injections. Intramuscular injection of hypnotics or tranquilizers are contraindicated due to the risk of hematoma formation. That is, when you give intramuscular injection, you are giving it into the muscle. It can again provoke bleeding and collection of blood in the muscles, which can be deteriorating. And the one injection that can be safely given to the hemophilic patient is intraligamentary injection. You can safely administer it without any factor replacement. Infiltration requires single infusion of factor replacement. So whenever you are going for infiltration, there is the factor has to be infused. That a single replacement is enough. Block is not at all recommended. IM is not at all recommended, as already mentioned. And again, block is not recommended even with factor VIII replacement. Minor hemorrhages can be controlled with moistened gauze pieces or topical application of bovine therapy. Replacement therapy is required prior to subgingival scaling. Care should be taken while placing intraoral films, high vacuum suctions, and saliva ejectors because all these contain sharp edges which can traumatize the soft tissue. If the soft tissue is traumatized, it can induce bleeding. And tooth extraction is not preferred in hemophilic patients. So whenever conventional pulp therapy can be done, it is preferred over tooth extraction. And the pulpal hemorrhage, it can be controlled by pressure. Electrosurgeries are absolute contraindication because initially you might get a clot, but later after some days there might be spontaneous bleeding from these sites. So electrosurgical procedures not recommended. Possibility of spontaneous hemorrhaging several days after such a procedure when clot lysis normally occurs. Primary teeth exfoliate without significant hemorrhaging. Sutures should be avoided as far as possible. Post-extraction instructions, when you what you have to give to the patient is first 72 hours. They should consume only clear liquid diet. Dairy products are discouraged since they leave a film residue. Next 10 days, consume only soft diet. Can return to normal diet after 10 to 12 days. So this is all about hemophilia.